Good morning and happy Friday. My name is Patrice Fidel. I'm your moderator for Friday Chalk Talk today. Today I have the honor of introducing Dr. Catherine Pollack to talk to us about ambivalence and motivational interviewing in palliative care. Dr. Pollack is a social psychologist and professor in population health sciences at Duke University School of Medicine. She is also the Associate Director of Population Sciences in the Duke Cancer Institute and co-leader for cancer prevention and control in the Duke Cancer Institute. She co-led the Palliative Care Research Cooperative Group with Dr. Jean Kutner and Christine Ritchie. She's been developing behavioral interventions for 25 years. She has studied clinician-patient communication and has developed programs to improve communication for almost 25 years among programs to improve communication. Among oncologists, palliative care clinicians, and others. She has also served as a communication coach for the past 10 years and is a Vital Talk senior faculty member. And she has directly coached over 200 clinicians, although we question if that's not a lot more. So thank you, Dr. Pollack, for being here, and the floor is yours.
Thank you so much. I really appreciate it, Patrice. And thank you, Marty, for the invitation. And this is going to be a relatively informal and hopefully interactive talk. I love working with palliative care clinicians. I have a ton of admiration for the hard work that you do. And when I have worked with you, the reason that I'm talking about it's ambivalence and reluctance is because these are the things that cause a lot of stumbling blocks for palliative care clinicians. And I will say it's funny, I have taught a lot of clinicians communication, and I will say palliative care, you guys are the rock stars. You're the best ones. And I'm not just saying that because if I were talking to endocrinology, I wouldn't say that. Because so I don't think I'm just placating you. You actually are the best communicators I've taught. And there are still situations in which those conversations are hard. And there are still areas in which folks get stuck and they would love more tools to put in their toolbox for when those situations come up. The two situations I wanted to talk about today, and I'm hoping, again, this is interactive, is when patients express ambivalence, meaning they really want to do something and they really don't want to do something. And this happens a lot. It happens a lot in general with people. Like I also am a tobacco researcher. And so helping people quit smoking is hard because people know they shouldn't be smoking and people really want to smoke. And that's hard to hold both of those things at the same time. And people do. And in palliative care, it's a little different because they may know that hospice is great and they don't want to go to hospice. They may understand it's really important and it's probably the right thing, and they also don't want to do it. And then you're stuck as a clinician, like, what do I do with this person who is kind of has this crossroads and these two very divergent thoughts? How do I help them make a decision about this? The other situation that comes up a lot is reluctance. Reluctance meaning the patient really puts up a pretty big roadblock and doesn't let you go any further. That is also an incredibly difficult situation to encounter, especially when you don't agree with what they're saying or what they're doing. And so our instinct when we see somebody putting a roadblock up is to try to persuade them to take the roadblock down. And what we've learned, and the reason I'm talking today about motivational interviewing, is there are some tools in motivational interviewing that help clinicians with exactly those two scenarios. Motivational interviewing came from the alcohol world, which is very similar to smoking, exercise, all of those behaviors that we try to get people to do. And what they learned is that people have internal drives to do things, and they are much more likely to do things when they come up with a plan and they tell you the reasons why they want to do something, and they resolve their own ambivalence with your help. They do much better than when we try to tell them what to do and we try to make a decision for them. And so I, along with Bob Arnold, brought motivational interviewing into palliative care. Now, the big difference, and I want to spend most of our time today going over some cases and talking through what we might say and how we might help patients in who are expressing ambivalence or reluctance. But the big difference in palliative care than when we use motivational interviewing in primary care is when we're talking about smoking or alcohol use or risky sexual behavior, there's a gold standard about what people should be doing. They shouldn't be smoking. They should not be having unsafe sex. They should not be drinking excessively. That the literature is really, really clear about what patients should be doing. And so as a clinician, you're guiding them to something, to a standard that we know will help them. Palliative care is different because you are walking in, you are all great palliative care clinicians. You walk in without an agenda. Even though clinicians will say to you, get me that DNR. I need that DNR. Get it for me. You can't do that. You can't do that. They want you to, but you can't. So you are coming in agenda free, but your agenda is to help patients figure out what they want and help them get where they want to go. And often patients don't know what they want. And when we're thinking about ambivalence, the reason ambivalence works the way it does, I want to go to hospice. I know hospice would be the right choice. I don't want to go to hospice. The only way that we can keep those two thoughts is to keep them in separate parts of our brain, and they don't intersect. You, as the clinician, when you see that, you bring those two boxes next to each other. And then people will feel that ambivalence, like, oh, shoot, I both want and I don't want. I didn't have consciousness of that, but now I do because this really skilled clinician has put them both out there in front of me. Often patients will resolve their ambivalence for themselves when those two things are put side by side. But as long as they're kept up like this, they can stay in that state for a really long time. And here you are waiting for them to make a decision, waiting, kicking the can down the road more and more and more. They might be staying in the hospital. They might be avoiding these things. And that's really frustrating for you as a clinician wanting some resolution as well. And so I would love to open up the floor for examples that you all have had from your clinical encounters where somebody expressed some ambivalence and what did you do? And we can talk about how motivational interviewing tools can help with that. And then let's spend a little time talking about what happens when somebody puts a roadblock up. Not going there, not talking about that. You will not be bringing that up. We will not be talking about that. And so Marty has a comment in the chat that you have an example, but wants to open up for other folks to put in. You can either put your camera on and say, and if you can have your camera on, that's awesome because it's more fun to see people and interact. If you're unable, then, by all means don't. But if you could think about situations in which you've been like, dang, I wish I knew what to do there because I didn't know how to approach this. And when you're going down a rabbit hole, you can feel it, especially because you are skilled communicators. When you're going down, you're like, oh no. And we're just trying to give you some tools so that rabbit hole you can step right over and not go in.
Dr. Pollack, I really appreciate all you said. It just like I was just head bobbing away and then I was eating yogurt, so I had to get off that. Didn't want to chew in your face. Anyway, thank you so much, Marty, for letting me join in on the chalk talk. Dr. Sinclair threw it out there to us, and I was like, oh my gosh, I want in. But I guess I wanted to say, there's so many examples, and what I've seen with our team and our patient relations is once, we come along in this serious illness of this unknown for the patients, and we come along and meet them where they're at. As you said, I always say, I come with no agenda. You're the captain of the ship. I am just your mate.
Yes.
I say your oncology team, this is what I deal with, is managing your disease and treatment. I come alongside you as a human being on a journey you did not choose to be on. And I pause and they cry.
Mm.
And to best help you to have good days, or I mean, however the word verbs come out at that time. I feel like we do come alongside people and there is roadblocks, and I honor those roadblocks. This is their chapter. They're writing it. I'm just there to support that chapter. I feel with us, it can't, like you said, they need that teapot, they need that DNR, but that will come with time. I feel like trust is a huge thing when they begin to trust us. So our initial visit is really just getting to know them. Tell me about what defined, what did you do in the past, blah, blah, blah. What brings you joy? Those things. And they develop that trusting relationship with you. And then those things come along. And like you said, bringing those boxes together, and it's going to happen in their time.
Yep.
We as clinician, me as a nurse, I want to fix that. I've been doing it for 40 years. I want to fix people. But I don't do that anymore since I've joined palliative care. I've come alongside in the last 7 years and just sat in their mud puddle with them
Yeah,
to
that's
see
beautiful.
what do they want. So I could go on and on. So I'm going to pause.
No, I love that, Annie, and I really love the way that you describe the work that you do, and fixing's hard. What's challenging, and I love that you're sitting in the mud puddle with them. What's challenging is when they are making a decision that doesn't really make sense. It doesn't make, let me rephrase, doesn't make sense to you.
Mm-hmm.
And what
I
I've
don't
seen,
need hospice now. I'm not ready for that yet. I'm like,
right,
tell me more.
right, exactly. What I've seen, even really skilled palliative care clinicians will go into persuasion mode. Let me describe for you what CPR is going to look like, and it's not going to help you. I'm going to break your ribs. It's going to be really traumatic. And they just start into that. And what happens when you don't want to do something and somebody tries to persuade you to do it? What do you do?
Dig my feet in like my horse.
You sure do.
Like
You're like,
horse.
oh, really? Watch this. Watch me now. You are
I-
firming me up now. And so, but we think we're doing the right thing and helping them see the right perspective. When we don't sit with them in their reluctance and acknowledge their reluctance, and we literally say, this is not something you want to do right now. You will know when it's ready. I can't make you do anything. Acknowledge their power because they actually have the power.
Right. I like to give them I often say, I'm just sharing this information as tools. I want to make sure you have all the tools and all the information to put on the table so that you then can make the best decision for you. And whatever decision you make will be the right decision because you've made it for yourself. I've said that for 40 years now.
Yeah.
And I continue that's the heart of my story. This is all about them. This is their journey. But I, as a nurse, don't want to not give them the information they might need to help them make a best decision for themselves. So I just throw it out there. I'm like, this is totally all yours and just food for thought. I'm here to support you in any way. And please let me know.
Absolutely.
So my
Absolutely.
question is, I think we've all, as palliative care clinicians, been in that spot where you recognize you're at a roadblock and employ a lot of the advice that you're giving us. What is your advice on helping the other members of the team outside of palliative care accept that that's where we are? Because I find that to be the frustrating thing is like you go and speak with the attending or speak with the nurses and what are we doing here?
Yep.
And that kind of
Yeah.
attitude or feeling coming at you. So how do you navigate that?
I appreciate that question, Patrice. And I think, it is really hard. And, motivational interviewing doesn't just work with patients. It works with everybody. It works with kids, believe it or not. So if any of you have teenagers or, it works with them too. And I think it's trying to help them have some perspective taking as well. And help, teaching them some of the motivational interviewing tenets. Like if they don't want to do something, the more we push them, the worse it's going to get. So the way that I try to approach this is I feel like they will come to to the decision that we think is right when they have more time and when we don't push them. And the way that I handle this, so what I'll say is not to the clinicians, but also with the patients is, I can see you don't want to do this right now. Would it be okay if I shared with you my thoughts on this? Would it be okay if I shared with you my recommendation? That doesn't mean you have to take it because you are the one in charge of this. So, but it's helping the other clinicians know I'm partnering with this person. And at the end of the day, they may not come over to what we think they should be doing. They're making decisions that make sense for them. My job is to give them all the information that, if they want it, my job is to give them the information if they allow me to share it, and to respect their decision. And that's all I can do. That's all I can do. And for them to, like Annie was saying, the more I respect them and the more I let them know that they actually have the power, the more likely they are to work with me and come around. The less I do that, the less they will come around. And so it's just letting the clinicians know, I know this is frustrating. I have a process for how I try to do this.
When I read your 2011 paper, Catherine, what I attempted to do was to apply it to talking to a consultant who has a behavior that we don't want. Because, right, traditionally, motivational interviewing is meant to address and stop unwanted behaviors. And so I'm thinking, well, what about these behaviors where teams call us to say, please get the DNR, or my patient needs hospice. And so in that case, I am actually trying to make a specific change in my consultant, not necessarily meeting them where they're at. And so I wanted to share some of my thoughts, because I put a whole bunch of buzzwords from your paper down into here. So, I mean, at first I'm thinking you got to begin by resisting that initial urge to tell them, that's not what I do. I don't do that. Because again, they might just dig in their heels even further. And instead trying to understand and listen to the cause of their distress. Because almost always it's because of something that they're worried about. They're worried that somebody is suffering or not understanding or not making an informed decision. And then using that, reflect back at them. You're worried that your patient is suffering, and even worse, not understanding the situation. Well, how about if today I work with the family and I can help them accomplish at least two goals. One, I'll help chip away at that understanding so they can better appreciate where they're at. And I'll help us all better understand what really matters most to them. Because then the team will appreciate if this patient really is suffering or what suffering actually means, and may give them a very different perspective, just using those motivational techniques on our consultants.
I love it. I love it. That's really fantastic, because you have common ground with them. And that, just finding that common ground can be so essential. You both don't want the patient to suffer. And what you were just demonstrating, Marty, was your empathy for them, which is really beautiful. Your perspective taking with them, just like you would want it, that just like you do with your patients. That they are not being malicious. They're trying to do their best. Yep. I do want to just briefly talk about some of the skills we use, some of the tools for ambivalence. So with somebody who wants to do something and doesn't want to do something, we often just ask them to list the reasons for and the reasons against whatever it is that they're struggling making a decision. Now, there is a little bit of a method to this, meaning if you do feel like there is something that makes a little more sense, the order in which you do the pros and cons matters. So for example, if you think that hospice is the right choice for them, you don't start with what are the good things about hospice, and then what are the reasons you don't want to do hospice? Because then the conversation ends on what they don't like. So you actually do it in the opposite order. What are your concerns about hospice? What do you think might be good about hospice? So the conversation is ending and going in the direction of good. Does that make sense? And that's how you're bringing those two things side by side for them. Like, this is what I'm struggling with, and this is the things I think are good. And then hopefully they come to some resolution. They may not do it in that moment, but you're starting the wheels turning for them. So that's one of the things you can do with somebody who is ambivalent. Something you can do with somebody who is reluctant is naming the reluctance. I can see you don't want to do this. The next thing you can say is, what would have to happen for you to be willing to do that? What would have to happen in your life for you to be willing to have this conversation? The critical piece of this is that there can be no edge in your voice at all. With somebody who's reluctant, if there's any kind of edge, that edge is translated into judgment. And when you feel judged, what's the number one emotion that comes up when somebody's doing this to you? What's the emotion?
Defensiveness.
Is it shame?
Yes, yes, absolutely. Shame. And I don't know about you, but shame is not my favorite emotion. It is one of my least favorite emotions. And so we have to work really hard. And I'm preaching to the choir. You guys are all tuned into this call. You are not judging. I will say, if people are making decisions that don't make sense to you, your judgment is going to come out, whether you like it or not. And so really getting to the place, like Annie, I love the way you're describing, like, I'm just sitting in the mud with you. I'm sitting here, I'm along on this journey. And so withholding that judgment. But so when you ask that question, what would have to happen for you to consider hospice? What would have to happen in your life for this to be something on the table? The other question we ask is, what is the worst thing that could happen if you went into hospice? What is the best thing that could happen if you went into hospice? Julie Childers was the other author on that paper, and I was talking to her about that skill, and she's like, I will never say that. That makes no sense to me. I would never use that clinically. And then 2 weeks later, she says, oh my gosh, I have been using that tool. It is so helpful. And I never thought I'd say it because it didn't make sense to me. But that whole, what's the best thing that could happen? What's the worst thing that could happen? But again, the order matters, right? If we're talking about hospice, you don't want to say, what's the best thing that could happen if you go to hospice? What's the worst thing that, because then how's the conversation ending? On the worst. So you want to ask it in, what's the worst thing that could happen if we went to hospice? What's the best thing that could happen if we went to hospice? And that can get people out of that, I'm not going to do it space. It gets them out of that space of like, no, 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 and gets them thinking, because the whole point of motivational interviewing is to get the wheels turning, cognitively, on these things that are really, really hard. These are hard topics because we're talking about death, and death is hard, as you all know. And so the reluctance is totally normal, because who wants to say, okay, this is it. I get it. That's hard. It's hard for loved ones. It's hard for patients. It's hard for you to witness. And it has to happen. And the way that you do it, if you do it well, those caregivers are going to benefit because they're going to have a good experience. They're going to have less bereavement issues because of the way that you're doing it, as opposed to them feeling bullied or pushed into something, and then they're going to have that regret. Like, we shouldn't have done that. That's not what we wanted. When they come to it, it's their decision. It's their reasons. They'll be at peace, and they will be grateful for your guidance on that journey. But it's such a different way of talking. It's such a different way than we're used to. There's a question. Oh, it's from Marty.
I'm happy to ask it out loud.
Oh, yes.
I'm curious if any of this, if your approach changes when you don't have time. Somebody is actively dying. They may not be here tomorrow. Yeah. I'd love to build rapport, but we have to have some decision today.
Yeah, that's a great question, Marty. And so what you can say is, we don't have to make this decision this hour.
Oh, interesting. I like that. Yeah.
I would like to come back in a bit, because it lets them, the beautiful thing about your position is you have expertise. You have expertise in what happens medically. You have seen a lot of people die. You know what this looks like. They have expertise in their experience. And so, but you have the right to share your knowledge with permission. You also have the right to say, this is really important to me. I can see this is not the right time to talk about it. This is really important. I need to bring it up again. Would it be okay if I came back in an hour to have this conversation? It is really important that we have this. I can see this isn't the right time. I need to have it. So let me give you some time, and you're asking permission the whole way to support their autonomy, and also letting them know, like, I have expertise in this. I will respect you, and I also need to do this because it's my job. That's a great question, Marty. Thank you for that.
So
it looks like we have 2 minutes left.
Yeah, I did have one other question. I often find some of the most frustrating ambivalence is when the patient, and this is kind of the definition of ambivalence, but presents with saying all the right things. And it's not just, I don't want to talk about it. It's not just actions presenting different, but in the case of a patient I had recently, I know that my cancer is advanced. I know that treatment would only make me sicker. I know that hospice is the right thing.
Yeah.
And then we just can't move beyond that conversation. So I'm wondering how you
I appreciate that. I appreciate that. And so my question to them is, first I praise them. You have thought a lot about this, and that's fantastic. I wonder what's holding you back. I wonder what's holding you back. And only you know that, and only you know what is gonna happen that's gonna make you feel differently. What do you think that might be? And that's that same question of, like, what would it take? I hear that you can't do it right now. What would have to happen in your life to make this an option for you? What would have to, and then they might say, well, if X happens, well, then you have that in your pocket, Patrice, because then when X happens, you come back and you say, I remember when we talked and you said, if X happens, that you would start to consider it. Well, X has happened. So then you can anchor them back to what they said, because it came from them. Mm-hmm. It came from them. And so that's one of the things that I do.
You're really just exploring where they're coming from in that realm. I often say, I see a picture. That being painted, the body, can I share with you what I see? And then they'll say yes. And then I've asked for permission when I first meet them. If I were to see changes coming along, how do you like to receive information? Can I share what I'm seeing? And so, it's that whole nurse statement thing. And then exploring, oftentimes, is it some trauma from past, or they had a bad experience with hospice with a family member? So share with me what your experience has been with hospice. Do you know anybody that's been in hospice? Really exploring those outside of that person's life or situation. Is there any clarification that needs to go on, with what hospice is all about? Did they have a bad experience with another family member? What's exploring what's maybe holding them back?
Yeah. Yep. That's great. Well, we're 1 minute over. I don't know how.
Well, that's okay. If there are no other questions, I'll let everyone get on with your day. I can't thank you enough. This has been really wonderful. Some good tips to take with us moving forward with patients. I really appreciate your time today. So thanks so much. Everyone
Thanks, everybody. Have a wonderful weekend.
Have a good week. Good weekend.